topic for me today is pre-treatment. Does it improve the quantity and quality of eggs or the embryos? So these days, before I begin, Dr. K Sharma sir, Brigadier sir, have highlighted very important points that before we start a patient or take up a patient for IVF, there are certain preliminary tests which we need to be done, like the basic test, apart from the routine test that we do, the rubella test, and especially the thalassemia screening, apart from the other tests that we do it. So it's not a hushy. We need to be very diligent with the investigations, and thoroughly these patients should be worked up, apart from all other the list for the IVF. So once the patient is ready for the IVF and the patient comes on the day 2, and we have planned that we'll give an antagonist protocol to this patient. Now before the when we give the antagonist protocol, we do face certain challenges. Now, what are these? Especially these challenges are much more common in the poor responders. These challenges are that there could be absence of synchronization of the follicular cohort before ovarian stimulation, and hence there is reduced number of retrieved oocytes and pregnancy rates. There is lack of flexibility in starting day of gonadotrophin stimulation, because if the patient has got the period, we preferably would like to start it on day 2 or day 3, unlike the long agonist protocol where the patient is on decapeptide or on leuprolide and we are little more flexible. So this flexibility is little less with the antagonist protocol. And both these things, as I said earlier, they are more pronounced in the poor responders, and hence there is a need for synchronization. I guess most of the specialists present here would agree with me that in poor responders, invariably we find the follicle size as maybe 11, 12 or 13 millimeter. One of the follicle would be like this sitting, or maybe another follicle also, and the rest of the follicles, they are smaller in size. So we aim to have a synchronous growth of follicles. Now what happens? Why this asynchronization occurs? We all know that during day 21 or the whenever in the luteal phase of the previous cycle, there is an FSH rise during the luteofollicular transition. This increased FSH, it leads to the accelerated growth of only few follicles. And when only few follicles, there is an accelerated growth, so the other follicles probably they don't grow, and then there is a concomitant suppression of few. So few follicles are growing very fast, the other follicles they don't grow, and hence it leads to poor synchronization and poor response to ovarian stimulation. Now in poor ovarian responders, what are the aims and objectives of this pre-treatment? Is to prevent the spontaneous luteinizing hormone surge, increase the number of pre-antral and antral follicles, and synchronize the follicular development. Hence, thereby with all these, when we are able to achieve all these 3 aims, ultimately it will lead to the increased oocyte yield. Now, what are the strategies that we have? We have androgens. In androgens, we have testosterones, dehydroepiandrosterone, DHEAs. Now the pre-treatment pituitary suppression agents, which are like GnRH antagonist given in the luteal phase or the delayed start, which I'll be covering, either estrogens given in the previous cycle or the oral contraceptive pills. Or there could be androgen modulating agents like letrozole, recombinant LH, HCG, and there could be miscellaneous like the growth hormone and CoQ10. I will just be going one by one. Now let's first start with the androgens. These androgens, either the testosterone or DHEAs, once we are giving these androgens, they increase the intra-ovarian androgens. Now once the ovarian androgens are increased, they help in the increased proliferation of granulosa cells, theca cells, and once there is an increased proliferation of granulosa and theca cells, the receptors present, the FSH receptors present on these cells, they also get activated, and hence this leads to the increased number of growing follicles. Now, this is like testosterone I'll be covering first. This was a randomized and a meta-analysis by Gonzalez et al. In 2012. They took 3 trials, 113 women in this testosterone group, vis-a-vis 112 in the control group. There was significant increase in the live birth rate and the clinical pregnancy rate. It also helped in reducing the dose of FSH required. But there were overall no difference in the clinical pregnancy rate per embryo transferred. And the number and quality of oocytes also, they did not find any difference in both the groups. So again, randomized trial by the Bosdu et al. And in 2016, this was another randomized control trial from 2014 February to April 2015. They took only the poor responders who fulfilled the Bologna criteria, and they gave testosterone pre-treatment for 21 days in 26 patients and no treatment in 24 patients. And they also did not find any beneficial outcome in these patients. Again, the testosterone, either it comes as a gel or it comes as an oral. The dose and duration, it varies. It can be either 10 milligram per day for the gel. There are variations in the dosage. Every author have used their these gels for different days and different amount. So they either use it for 10, 21 or 4 weeks. So the recent evidence is unconvincing. There is a recent double-blind placebo-controlled trial, the T-Transport trial. The number mentioned for the T-Transport trial is this, where they have given the 5.5 milligram daily transdermal testosterone for 2 months before the IVF. However, we all are awaiting the results for these, that whether given for such prolonged doses, does it give any benefit? There was a Balash study at all also, where they did it for just 10 or 12 days, which I have just mentioned above. So they also did not find it any convincing benefit with the giving by these testosterones. Another, we all are very fond of giving DHEAS. The literature suggests that 26% of the IVF clinicians, we add DHEA as an adjunct to the poor responders. Now, why and what important role does DHEA plays? This is important in the synthesis of testosterone and estradiol. I have not got that diagram, but it is just important to remember that in the steroid pathway, it is important in the synthesis of testosterone and estradiol. So, there is plethora of studies considering DHEA pre-treatment, but where have they found to be beneficial? Once you get the DHEA levels done and the DHEA levels are less than 180 milligram per deciliter, they have a better effect. They provide greater possibility of attaining more than 3 oocytes. Again, a trial, this is another meta-analysis by Nakiviken et al., where they took 200 IVF cycles, 22 articles included. They did not find any difference in the clinical pregnancy rate and the number of oocytes retrieved. However, in fact, it was an eye-opener that the number of oocytes were less in the DHEA group. And they concluded that well-designed and more RCTs are needed. This was again the clinical pregnancy rate and the miscarriage rate. So we see that the clinical pregnancy rate did not increase, and the miscarriage rate also increased in the DHA group. Now I'll just give you the explanation why is it like this. Now what happens once you're giving the DHEAs, the hyperandrogenic content of this rises because the testosterone also rises. And once this is a hyperandrogenic state, then it becomes like a polycystic ovarian syndrome where the male androgens or where the male hormones are excess in amount, and hence they do not lead to the follicular growth. So just a word of caution, whenever we use DHEAs, it has to be maybe either 2 or 3 months, not so prolonged. And when we start the stimulation, probably we should start the DHEAs, because otherwise increased androgens will hamper the follicular growth by the hyperandrogenic condition. and the hyperandrogenic environment in the ovary. Now, another the miscellaneous drugs like that I would be covering here is simultaneously is the growth hormone and the CoQ. How does growth hormone help? We use definitely, I think majority of us have used this at one point or the other, especially in the poor responders. Now, growth hormone, like we all know that insulin growth factor, it helps in the recruitment of the FSH receptors on the granulosa cells, their differentiation through the aromatase activity, induction of LH receptors, and synthesis of progestins and proteoglycans. And this insulin growth factor 1 is dependent on the growth hormone. So that is why the growth hormone plays an important role. It doesn't play a direct role, but yes, indirectly by stimulating the insulin growth factor 1, it playing an indirect role. So this was a very beautiful article. This was a 10-year perspective on the utility of 3 adjuvants often used in IVF, that is growth hormone, melatonin, and DHEA. Huge number of cycles, 3637 in 2376 women, a 10-over period study in Australia. So they found it and they concluded that growth hormone is beneficial for where there is a poor quality of embryos and where there are nil embryos cryopreserved. Plus, there are other poor prognostic factors, like especially where there's an advanced age, more than 40 years, poor ovarian reserve, less than 5 or AMH less than 5 picomoles, insulin growth factor is in the lowest quartile, or there is a recurrent implantation failure where there has been more 3 failures of embryo transfer. So, we have to be very, very particular, right, left, and center. We say, okay, this patient is Bologna criteria, and we just start adding growth hormone, DHEA, or testosterone. We have to be very, very selective in using all these agents because they might do more harm than the benefit. Because that is what their observational study was, that it may actually reduce the live birth productivity raised if used on a woman with poor prognostic factors. So, especially growth hormone, these are basically, I would say, the indications for using the growth hormones, maybe age more than 40, AFC less than 5, and 3 RIF. Again, similarly, CoQ10. Now, I think quite a majority of us have started using this CoQ enzyme 10, but are we really justified? And let's see what the evidence has to say. What is the role of CoQ enzyme? CoQ enzyme is an essential component of the mitochondrial electron transport chain and hence the ATP production. Now, what happens as the woman ages, the mitochondrial dysfunction is there. Once the mitochondrial dysfunction is there, enough ATP production is not there. Once the ATP production is not there, then the growth of the egg, from germinal vesicle to the metaphase 2, we need ATP. And hence, if the CoQ enzyme is deficient and mitochondrial dysfunction is there, then this proper growth from germinal vesicle to metaphase 2 is not there. Hence, there is an increased aneuploidy rate. And thus, with the addition of CoQ in the IVF media, especially in the older age group, has shown to be beneficial, but mind you, but not in the younger women, because in younger women, we do not see any mitochondrial dysfunction. Again, this was a study by Bentov et al., where this was a double-blind placebo trial in the women age group of 35 to 43. They randomized women, either study group as CoQ taking 600 milligram for a period of 2 months and the control group. So neither the ovarian stimulation variables and neither the aneuploidy rate differ between those who received CoQ10 and the control group respectively. So hence we need more studies to prove that. Again, this was a randomized trial, especially in the Poseidon group 3, where they gave 600 milligram. And again, they summarized that this study showed that they may have a beneficial effect on ovarian stimulation, but there was no advantage with regard to the pregnancy and the live birth rate. So, all these drugs, whether we use CoQ, whether we use growth hormone and all this, we need to be cautious. And now I come to the pre-treatment suppressive agents. Now these pre-treatment suppressive agents are, one of them is the GnRH antagonist, where we can give the in the luteal phase. Now if we give that in the late luteal phase, because we all know that GnRH antagonist, it works by the competitive mechanism. So once the receptors are blocked by the antagonist, by the competitive inhibition, there is a sudden decrease in the gonadotrophin levels, and hence immediate luteolysis takes place. And once these luteolysis of the follicles takes place, once she gets the period, there is a uniform cohort of follicles. So it is given for 5 consecutive days. There is a more synchronous follicles, there is high maturity rate, more cleavage stage embryos, and the high blastoration rate. But despite all this, there was no difference in the clinical pregnancy rate, which was not higher. This was a study by the Safak Olgen et al. And again, another study by the Zing et al., and where they also showed that the GnRH antagonist pre-treatment before ovarian stimulation, 136 normal ovulatory women vis-a-vis they gave it the GnRH antagonist. The number of retrieved oocytes and the pregnancy outcome did not significantly vary. Now, there is another delayed start antagonist. This antagonist protocol which I showed, this was given the antagonist during the luteal phase, which means the cycle previously starting to it. Now, the delayed start antagonist is that you have given the estrogens in the previous cycle, and you've given the estrogens, and once she gets the period, now this is the control group where MCD2 is the menstrual cycle day 2. You straight away start with the gonadotrophins. You add antagonist when the follicle size is 14 mm or day 6 of the stimulation, and again you follow the routine protocol. But the study group, what do they do? The menstrual cycle day 2, the girl gets the periods, and then the antagonist is given maybe for 3 to 5 days, and on the 5th day you start the stimulation. So you have given the antagonist for 3 days, though few literature studies giving it for 5 days also. And again, once the follicle reaches 14 mm, you again give antagonist following like your control group only. So what did they found? They found that in the there was no basically difference in the number of oocytes retrieved or in the number of in the clinical pregnancy rate. So hence even this also didn't work much. Now, this was a Cochrane about the another suppressive treatment effects like the oral contraceptive pills, progesterones or estrogens. These oral contraceptive pills, we give it for the last, in the previous cycle, we give it either for 16, 18 or 21 days. The estrogens, we give it either like say in the luteal phase where we give it from day 21 and we continue till day 1 of the period, and the progesterones also we give it like for say 5 or 6 days. Let us see what does the Cochrane has to say about this meta-analysis. Now this 29, sorry.
Yeah.
Anju Rastogi, please mute yourself. Please, Anju Rastogi.
Yeah. So 29 RCTs were there, including 4701. This was a very big trial. They concluded, the Cochrane review concluded that combined oral contraceptive pills pre-treatment was associated with a lower rate of live birth or ongoing pregnancy rate than no pre-treatment. Evidence for progesterones or estrogens, but overall the quality of evidence was very low or moderate, and the main limitations were the risk of bias and imprecision. You know, because once you have given these drugs, obviously your result would be biased. Okay, I've given this. So, but because of the low quality evidence, these data just suggest that. And however, there have been many studies, more studies on the contraceptive pills, because I think of all these drugs, we all tend to give birth control pills in the previous cycle. So this is the commonest form of drug that we give it. So this was again a very important, very nice study by the colleague Bianikis in the human reproduction. He said that there was no significant difference in the ongoing pregnancy rate as per started cycle, and this results in a significantly higher early pregnancy loss. Because there came a time, I know everybody, we all were talking of it, by giving the birth control pills, we are reducing the pregnancy rates. So subsequent to all these, there has been studies which have shown. So Polybianskis shows that there is no difference. Another study by the Rombots et al., he says that OC treatment prior to the antagonist protocol can be successfully applied to schedule the patients, although more days of stimulation and more FSH is required than without scheduling it by giving the OCs. Again, this was the trial by the Cedrin et al., the effect of oral contraceptives, synthetic progesterones, or natural estrogens. They concluded that a 5-day free interval period after OCs or progesterone offers the advantages of gonadotrophin recovery and hence homogeneous follicular cohort, whereas early FSH rebound occurs after the estrogen pre-treatment, argues for a short free treatment. Now, we give OCs for 15 to 21 days, progesterone for 10 to 15 days, or natural estrogens for 10 to 20 for 15 days, as I just mentioned above. So if there is a washout period for 5 days, then they say that the results are better, because by the washout period for these OC pills, where they reduce the FSH and where they suppress the pituitary or the thalamus and does not lead to the rise in the FSH and the LH, the washout period is 5 days. So a word of caution is, when you give OCs, then preferably to start the gonadotrophins after 5 days of the last pill. So now this I have tabulated with all the studies, the differences between the OCPs and the estrogens, because this is a very, very controversial topic about the oral contraceptive pills. Now people have moved from oral contraceptive pills to estrogens. Let's see the differences and let's see what's the final verdict is. So in the oral contraceptive pills, the mechanism of action is that it leads to the decrease in both FSH and LH levels, whereas the estrogens, the recovery, gonadotrophin recovery after 5 days washout period, and if you are giving estrogens, the gonadotrophin recover after a 3 days washout period. The suppression with the oral contraceptive pills is stronger. You get more homogeneous cohort. Here the suppression is mild. It is started in the follicular phase. It is started in the luteal phase. Ovulation is not suppressed. So you know why this is, estrogen is becoming a more favorite as compared to birth control pills, because you are giving one more trial. The patient can try one more cycle, because in the follicular phase, if you have given, she will not ovulate. But if you give it in the luteal phase, she has already tried, ovulation has already taken place. So you are giving one more cycle benefit to the patient. The gonadotrophin dose is similar in both the groups. In normal responders, there is no increase in oocyte yield, because right, left, and center we give it to the patients without wondering whether she is a normal responder or a poor responder. So in normal responder, there has been no increase in oocyte yield in both the groups. Whereas in poor responders, they found a better yield, but eventually the reproductive outcome, the clinical pregnancy rate and the live birth rate did not matter much, as the controversial points which the Cochrane highlighted, that there could be a decrease in the pregnancy rate. So this was also similar for the both. So reproductive outcome same, adverse effects same. Now another important, why these OCPs were so much against, and why the literature came so much, that you should not be using birth control or OCPs. Why? Because they are suppressing both the FSH and the LH. This LH does have this suppression of the LH does have a negative impact on the endometrial receptivity. So that was the main reason which led to the people to move towards these estrogens, because once you're giving estrogens, you're not suppressing the LH hormones, and hence once the LH hormone is not suppressed, there would be adequate secretion of progesterone, and hence the endometrial receptivity will not be hampered as in cases of giving the oral contraceptive pills. So eventually, what does the final conclusion and what does the literature final verdict says? Now it says that in normal responders, you should not be using either OCPs or estrogens. But yes, if there are and poor responders, then maybe either OCPs or estrogens. If you have to start these gonadotrophins, give it a proper washout period for 5 days between the last tablet of your OCPs and the start of the gonadotrophins. So once there is a 5-day washout period, your reproductive outcome will not deteriorate. So the main role of OCPs and estrogens is basically to reschedule the cycle. Like suppose, patient coming from far off country or from another state, they have booked the tickets, you need to plan. Then basically the main role is this only, OCPs and estrogen is to reschedule the cycle. And moreover, in this advanced era of vitrification and all, we are not that much worried using OCPs in the cycle prior to the prior to the stimulation or as a pre-treatment, because majority of us are moving towards the frozen embryo cycle. So where there is probably no danger of the negative impact on endometrial receptivity. So with this, I think I have covered the majority of the drugs that we use, and the take-home messages is that pre-treatment strategies preferred in poor responders and to be used cautiously in normal responders. Growth hormone, DHEAS, CoQ10 may be promising as a pre-treatment before IVF only in selected group of patients, which I mentioned earlier. Studies including pre-treatment pituitary suppression with GnRH antagonist, estradiol or OCPs, they are either small, retrospective, or with patients serving as their own control. So we need more randomized studies to prove whether should we be using them right, left, center, or should we be selected. Now, pre-treatment by either estradiol or GnRH antagonist administration, it reduces the pace of growth and improves the homogeneity of the early antral follicles during the early follicular phase, but no clear benefit has been noted with regard to the live birth rate. Because you've given the estrogens and you've given the GnRH antagonist, so that is what the study and the literature is trying to show us and guide us, that definitely you might find a good homogeneous cohort of follicles, but the eventually net result is not beneficial. So there is no beneficial, the live birth rate does not increases. The information on most important outcome of assisted reproductive technology, the pregnancy and live birth rate, it remains clear with no sound evidence, and large prospective studies that should validate the specific mode or combination of pre-treatment measures are required. So with this, I think, so I just conclude, and the take-home message just in 5 lines, if I have to say, that we have to be very selective in giving the growth hormone, which I said above 40 years, poor responders, recurrent implantation failure. DHEAs, if you are using, you have to be very, very particular not to use when you are stimulating and not to be used for more than 2 or 3 months, because by creating an environment of hyperandrogenism, you are creating much more harm than doing a benefit. Coming to the OCPs versus estrogens, we are moving towards estrogens, but they are to be used in poor responders, not in normal responders, and mainly for the rescheduling of the cycle, because eventually they also have not proven to be useful. Despite giving, a cohort synchronous growth of follicles, they haven't proved to be useful as such. So with this, I think I conclude my talk, and I just stop sharing. And
I think, Dr. Shalini, it had been absolutely wonderful. Each and every point you crystallize. In fact, in my own mind also, I become very clear that when you're talking of pre-treatment, it was only for poor responders and not for normal responders. So I think your sum up story is very clear that, no additional thing has to be used for normal responders.
True.
Only the poor responders one has to use, and I think whatever the strategies you said, the end of the story is that it does not increase the pregnancy rate.
Yes,
It does not, if it is not increasing the pregnancy rate, then, the things. Main problem is, in a poor responder is to have a homogeneous cohorts. And for that, we people have been using for a long time OCP, and now people are switching over to estrogens, because the wash of time with OCP is 5 days, and for estrogen it is 3 days. And
yes,
as you already said, that it probably may be affecting the endometrial receptivity, because now many times you find that you transfer a blastocyst, you have a great endometrium, and still the pregnancy is not there. So they have nothing but, they said that endometrial receptivity had been bad. So in that particular light, we still use OCPs. But I think, you have not given a clear cut advantage, that in case given choice between OCP and estrogens, which one will you prefer, as far as your choice is concerned? I think, each one of us must definitely say, what is my choice for the same? So what is your comment on this? Before I can see Dr. Sushma Sinha is also here. Welcome, ma'am. Dr. Shalini.
yeah. So, ma'am, it depends. Suppose the patient is coming in the follicular phase, then at times, and we have to plan the cycle or reschedule the cycle. I do prefer giving birth control pills, but if the patient is giving in the luteal phase, then we have to give the estrogens. So that is how I decide which pre-treatment is to be given. And mainly in the poor responders, not in the normal responders, I
Yes,
give
I
it,
think you
ma'am.
made it very clear. Brigadier
Yes,
Sharma, your comments are needed, because
sir.
I think after Dr. Shalini's talk, let this particular lesson be cleared, that we are not going to use any adjuvants in a normal responders. Please, sir, over to you.
Yeah, I think she covered the subject very well. And if you ask me my personal choice whether I would like to give the OC pills or the Progonova, that estrogens, before the IVF. On the patient, as she mentioned, she comes on the follicular phase, and if I find there are some follicles which are present from the previous cycle, like I do the day 2 ultrasound, I find there is a 12 millimeter, 13 millimeter follicle which is there, or there is one persistent corpus luteum which is present from the previous cycle. In this patient, I will like to give her OC pills, because that would suppress the. Otherwise, this follicle will grow, and then the next cycle when I do the day 2, I will find the follicle is persisting and become a cyst now. So a patient who is having early, folliculogenesis, or on the day 2, if I find some remnant follicle or corpus luteum, there I would prefer to give the OC pills. And if it is clean pelvis that time, and all the follicles are small, these are poor responders. In those cases, I may give estrogen in the late, luteal phase only. Now, a few words about the Madam CoQ. The CoQ, yes, as we all age, we know that our mitochondrial function is affected, and coenzyme Q2 is very important for the ATP release. And it's also found that in the cases of PCOS, the coenzyme Q2 function is deranged. So this is another subgroup of patients where you may have to give CoQ, before the IVF, to get a better quality of the oocytes. Otherwise, you'll find many times many oocytes come, but the quality of the oocyte is very poor. So in PCO patients and the poor responders, there is a place for giving CoQ 300.
Very rightly
The
said, sir.
supplementation is expensive.
And
uh, and people, whenever a new thing comes, everybody starts using it. It may be a year or 2 years down the line, people will find that there had been a no difference. Dr. Sushma Sinha, you want to make any comment on Shalini's presentation?
warm welcome, Sushma Sinha, ma'am. Ma'am, are you there?
Unmute yourself, madam. Unmute yourself. Unmute.
What I want to say is that hard presentation, but Recently only I presented on the all the adjuvants and all. And what I understand, the bottom line is that none of the adjuvants actually work. And about the coaching, there were a lot of papers, Chinese papers, other papers, using of more than 600 milligrams increases the chances of pregnancy. But I have tried that and it doesn't work for me. So as such, although still I am using aspirin, like everybody is using, but about that also I am not sure how much it works. So I am not very good advocate of using to with you.
Yes, ma'am.
Comment? Anybody wants to make any comment?
I think Dr. Geeta Khanna was also seen sometime in between, madam. Is she there?
Geeta Khanna is here. Dr. Geeta Khanna, you want to make any remark? I think Shalini, we will move on to the second topic.
Okay, yes, ma'am. So another, thank you